Welcome, everyone. It's so great to have you today. You were invited because you are registered as your hospital PQI liaison, or maybe you are using our PQI report, and we want to make sure that we cover some of the basics, some of the most frequently asked questions that we always get, so you are able to read your report at your best ability. And also, we are going to go through a couple of additional indicators that have been coming up lately a lot. So, with that said, welcome. Thank you so much for joining us today. It's always great to have you all. And we are going to have two sections for questions. So, if you have them, please hold them to the sections or just write them on the chat and we'll get to them during those times. Just as housekeeping, please make sure that you mute yourself so we reduce the background noise. If you have any questions, enter it in the chat or please raise your hand, and your hand should be under reactions in your Zoom dash. And this webinar is being recorded and will be available in our YouTube website once it's processed around next week. Please meet our data team. I think most of you know us by now. My name is Estefania Rubio. I am the Associate Director of Healthcare Data and Informatics for FPQC. In my team, I do have Shelby Davenport and Alexa Mutchler, two very excellent and very gifted data analysts that have been working with our team for a while now. Shelby has been with us for almost 2 years and Alexa for a year. And they are always available if you have any questions. Their information is right there, and you will hear from them today as well. In today's agenda, we are going to have a brief overview of what is PQI. We do have quite a few additional PQI liaisons. For some of you, I know that you have been with our program for a while, and this may be a little repetitive, but this is just to make sure that everybody is at the same playground to start with. And then we're going to talk about severe maternal morbidity measure. It has been coming up a lot lately because we're focusing on hypertension and hemorrhage. And so we tend to talk about severe maternal morbidity when we talked about those two issues, because prevalence alone doesn't tell us much, but talking about those patients that got serious complications tell us a lot about our system of care and possible preventable actions. And so we're going to talk about severe maternal morbidity today. And then we're also going to go through how you should be using your PQI report for future and current initiatives. And again, we will have two opportunities for questions. So with that said, what is PQI? PQI is the longest standing initiative for FPQC. It started in 2012 with a lot of coordination between agencies. So FPQC could get data that hospital already reports to the state in an effort to provide reports so hospitals could individually look how they are performing compared to other hospitals in the state for very important perinatal indicators, right? And so those reports go out twice a year at the end of January and at the end of June. However, those are updated more frequently, up to quarterly, if you request it and if you access the report online. So if you have interest in accessing the report online, please make sure to follow up with our team. Alexa Shelby can help you, to get the USF credentials so you can access that report online and get more frequent updates. Every hospital has a PQA liaison, and that is our contact person. We are hoping that the PQA liaison is going to be able to review the report every single time they get it, and then highlight those opportunities for improvement within the hospital, share it with the other clinical experts and leads at your hospital, and make sure that those opportunities are well discussed among your teams to make sure that if there is anything that you need to work on, that you bring your team on and find opportunities to work on those issues. But also it's an opportunity to celebrate wins, right? If you have been working on something for a long time, you will be able to see those trends going down, hopefully. And then also once you compare them to other hospitals in the state and hospitals that are related to your hospital, you will be able to see changes over time. With the perinatal quality indicators, we are looking to monitor and improve maternal and infant health outcomes in Florida. It does identify variation in care. So as I was telling you, PQI gives you the ability to see how the other maternity hospitals in the state perform, how high the rates are or how low the rates are, if the variation is wide or not as wide, and where you lay compared to others. It does in the state inform policy and resource allocation. The report is shared with other agencies and is part of our conversations when we discuss and we choose the initiatives that FPQC is going to work on statewide. So it definitely helps us guide our work and the work of the state. And it also should, at the hospital level, guide quality improvement initiatives. In the perinatal quality indicator set, we have 9 key indicators. You can see them here. After the name of the indicator, you see where it comes from. So non-medically indicated deliveries is the PCO1. It comes from the Joint Commission, and we use the methodology of the Joint Commission to calculate it on our end with the data that is available to us. So you can see that NTSV cesareans is PCO2. That comes from Joint Commission as well. The comparative measure, that is something that we are using Joint Commission and SMFM guidelines to create a comparative NTSV measure that you can see and compare if they are about the same rate. If you have questions about that, we can jump in a call separately and we can go into much deeper conversation about what it means. But we do have published manuscript that we are happy to share the link to if you are more interested on exactly what it covers. And you can see that we have additional ones. We have failed inductions of labor, we have severe maternal morbidity, unexpected newborn complications, severe hypertension, obstetric hemorrhage, and neonatal abstinence syndrome. And after that, you see the source of where we get the information to calculate the indicator for.
So where does the data for the PQI report come from? You can select all that apply. We've got birth certificate data, inpatient hospital discharge data, link birth certificate to hospital discharge data, and then the hospital reported data to FPQC from chart abstraction, or that patient level data that you guys put into REDCap. So if you chose the first 3, you are correct. So the PQI report, that data that's feeding the report is coming from birth certificate, inpatient hospital discharge, and the link birth certificate to hospital discharge data. So great job to all you guys that responded. Again, we do not include the hospital data that you guys do for the patient abstraction. That does not go in the PQI report. That is your separate, hospital initiative reports that we send to you guys every month. Okay, so now we're going to go through each of those data sources and kind of where they come from and the implications behind each of them. The first one is the birth certificate data. So we have included the Florida Department of Health slides, as you can see, because hospitals report their birth certificate data to the state, and then the state reports that birth certificate data to us. So as you can see, there are, over 200,000 births. So just about every single birth from every single mother and Florida babies is reported on and collected by the Department of Health. So when a birth certificate clerk has one to be filled out, they have 5 days to fill out all the measures for that birth certificate, or they get fined. So it is very timely and prompt when that information is reported. There's over 300 pieces of information that those clerks report on for Florida mothers and babies. And it's a very consistent source of health information. Like I said, we have like a 99.99% rate of all births are filed electronically through this electric birth record system. And there is data checks built in. They have the quality assurance and statistical staff that work with hospitals to go over these birth certificates to make sure that the data is complete and accurate. Next, we have inpatient hospital discharge. That is reported to us from the Agency for Healthcare Administration, or AHCA. So the stuff that they report on is acute care, intensive care, psychiatric, and newborn live discharges and deaths. This data also is distinct and incomplete, so hospitals upload quarterly data to an online portal. If there's any errors, they get error messages that come up and give them a chance to go back and report more accurate information. And then once all their error messages are cleared, they submit it to an analyst to review. That analyst then sends the report back if they find any discrepancies to the hospital to update. So you kind of have this two-tiered system of checking for accuracy to make sure that it's complete and succinct, and accurately represents what the hospital has done. And so once it's been had that double verification, then the hospital can confirm for submission. And so it's really important that we have this two-way verification system to make sure the data is accurate, because this data is publicly available. So different entities like newspapers or other organizations can request this data and analyze it and publish on it. So it's really important that hospitals not only go through these verification ways, but they can also look back retrospectively 12 months in the past, to verify the information is correct and all the information they submitted is accurate. And then that third data source that we talked about for our PQI reports is our linked data. So the Bureau of Vital Statistics links our birth certificates to inpatient discharge data twice per year. So it's a lot of information, a really big file. It has all these ICD-10 codes plus the birth certificate details, really rich data source. But because it's two big data sources coming together and that inpatient data that I talked about has all those verifications to go through, um, this data has kind of a lag in when we receive it and when it's been linked. So this is the first page of your PQI report. I'm sure you guys have seen it. If not, this will be the first page you look at that you'll get from us in the PDF form. Each of your indicators are listed, and there's also the data source in green, the date it is available or covering, and the corresponding indicators below that in gray. So if you're ever unsure of where this information is coming from, you can check the green bar and the indicators that are listed below. So now I've got another question for you all. So regarding the reporting periods for the perinatal indicators, select the correct statement. So the majority of you are correct. The indicators in our PQI report do have different reporting periods, some being more current than others. And again, that has to do with the way that they're being reported, the time it takes to verify each of them, and to get them all correct and approved. So as you can see, below the data source in green, you'll have the last 12 months of available data in blue. Now I'll pass it over to Estefania. Thank you so much.
Okay, before I move on, does anybody have any questions about data sources or timelines for your PQI indicators? I know it can be a lot, especially if this is your first time getting the report. We do have those three sources. Fortunately, none of those information you have to report directly to FPQC. As Shelby said it, those are things that your hospital report to the Bureau of Vital Statistics through the birth certificate or to ACA for the inpatient hospital discharge data, and we get it from them through special data user agreements. And so luckily, your hospital doesn't have to report any data to us to get PQI, the PQI report. We get it from already available sources. So I don't see any questions in the chat or any raised hands, but if you have any questions at any point, don't forget to put them in the chat. So the next thing we were going to cover today is this severe maternal morbidity indicator. We have been talking a lot about it, and these are the unexpected outcomes during the delivery hospitalization that result in significant short and long-term consequences to a person's health. We know that these are the sentinel events, the near misses. There's a lot of names that we see out there that represent these severe maternal morbidity cases. SMM was defined by the CDC many, many years ago, and it's a compilation of 21 comorbidities or significant events. And they are all defined through ICD-10 diagnostic and procedure codes. And so we get those ICD-10 codes through electronic health records. And those to us are reported through the inpatient hospital discharge records that go to ACA. And those are also included in claims data. So sometimes researchers may use it through the Medicaid claims data. But what's important is that you do have those ICD-10 codes, right? You're a hospital are the ones that are coding all of those. So many hospitals have now created reports with their IT department so they can actually see and track those SMM events in a more timely fashion. You don't have to wait for us to send you the report. You can just check on your own reports. And it's been great to see whole systems create dashboards so you can quickly access your SMM numbers. And the importance of having those SMM numbers in front of you is because those are the ones that need to be reviewed. Those are that benefit a lot from the structural case reviews. But we also know that it's a difficult measure to put in place through IT because it has a lot of conditions that you have to list and you have to follow an algorithm. So if your hospital hasn't done it yet, you do have PQI to check your numbers with. This is the list of SMM codes, right? Not codes, but the conditions. So you can see that 1 through 21, it goes through a lot of the conditions that may have the patient go to the ICU. So, these are the patients that get really, really sick very, very quickly, and that some of them may actually have fatal events. And so when we review SMM, it's a way to prevent mortality in a way, because we are going to capture opportunities in the system for more timely care and ways to prevent them. And so the importance is really, really out there. But the list of conditions, as you can see them, is quite a lot. And so when we look at the ICD-10 codes, we're looking at over 300 codes. And so when you have to put that in your IT system, it really requires a very specialized analyst in your EHR to do it well. So you can really capture all of those conditions for all the patients that come for your delivery. The AIM website has wonderful tools. So we have the link right here, and let me see if I'm able to share with you exactly what is on the website. Let me just jump to a different window, so we can look at it together. But the AIM website has a wonderful list of resources that I highly, highly encourage you to visit and to review. Let me see, for some reason it's not, today's Zoom is not letting me share easily, but here you have it. The link that Alexa dropped in the chat right now will lead you to the M website. And in the M website, you have an introduction, quick video of what SMM is, why we track it. And then you have the SMM code list. So when you reach out to us and ask us for the code list, we basically get it from there. And this is the best place to get it because it will be the most updated list. And you can see here in the spreadsheet how you will have the ICD-10 codes for each of those conditions. So that is going to be your numerator. For your denominator, it's going to be all your births. So every single patient that comes to deliver will be included in the denominator. And then for the numerator, you would capture every patient that had one of those conditions. There is a more comprehensive list that has, because I21XX is letting you know that you should include all the ICD-10 codes that have I21 at the beginning, right? And so if you want the more comprehensive list that gives you the additional 2 numbers at the end, we do have that list. Just reach out to us and we're more than happy to share. But if you want just an overview, here's where you would find it. You have all the conditions with the ICD-10 codes, what they mean, if there has been any changes on the way that they are calculated. Some of them are coded only through 2019 or 2020. You can see here in the note. So it will tell you in detail exactly what is happening with each one of those codes. So this is the most accurate, the best place to get your code list if you want the larger one. You can always reach out to us. We're more than happy to send them to you. There's also the SMM flagging tables. So once you are able to capture in your EHR the SMM codes, you can upload them in the flagging tables and you will get an additional set of cases that need to be reviewed. But for that, you would need to upload those cases. You have a guide to implement the SMM algorithm, so much more detail on exactly what the SMM algorithm entails. Truly, you only have to identify well your denominator, which is all your births, and so you have some, again, ICD-10 codes that you can use for that, and then making sure that the numerator is capturing well every single event per patient. And then there's additional, if you are doing research, there is HCAPS data that you can use. But for your hospital, um, the, the, the links that will help you the most are these three: the SMM code list, the flagging tables, and the guide to implementing the SMM algorithm. Okay, let me go back to our spreadsheet. Not a spreadsheet, but our documents. Okay. All right. So why do we monitor severe maternal morbidity events? As I was telling you before, that acts as an early warning system for identifying preventable complications before mortality occurs. And so it's very important that we capture those sentinel events, especially patients that go to ICU or have massive transfusions, because those signal severe breakdowns in care. It's important to have those structured case reviews to help identify system level gaps and delays in treatment. There is a lot of guidance in the AIM website as well on case reviews, on how to conduct them, how to put together a multidisciplinary team to conduct case reviews. So if your hospital needs more help or guidance on that as well, let us know. We're more than happy to connect you with those resources. And we do have the coach mentors that are working for PROMPT and for OHI that could also help you bounce ideas on how to have that in place. But overall, having a system in place to identify severe maternal morbidity cases is essential to identify those opportunities of prevention. And then within FPQC, the FPQC report, the PQI report, you will be able to identify differences by race, ethnicity, insurance, and hospital type. So the value of PQI relies on that, on the fact that you can benchmark and you can compare your hospital with other hospitals in the system. And this is how the report graphs look like, right? So for severe maternal morbidity, please remember we always exclude blood transfusions alone. So if patients had blood transfusions and they also had another of the conditions in the SMM list, they will be here. But if they only had blood transfusions, they will be excluded because documentation for blood transfusions is not well done or comparable across hospitals in Florida. And so nationally, actually, that has been a recommendation to exclude blood transfusions. So here you will have the conditions that we saw before, like those very important events like acute renal failure, cardiac arrest, hysterectomies, those sort of things. And so you can see very easily for this particular hospital that is graphed in black that they have one of the highest rates in the state. So it's important to compare with hospitals that have a similar NICU level or a similar level of maternal care if your hospital has a verification, so you can see if that gets adjusted. So if you have access to the online report, you will be able to use the slicers to see if the rate goes to a different quartile. Because, for example, for this particular hospital, they have one of the highest rates in the state, right? So for them, the question would be, if you only compare two hospitals with your same NICU level or with your same level of maternal care, which would be the ideal comparison, are you performing better when you compare yourself with other hospitals that are more similar to yours? And so if you are able to access the report online, you will be able to use those slicers and see if your comparison improves for the quartiles. But overall, this gives you an idea of, are we improving and are we declining? Are we stagnant? For this particular hospital, you can see that their rate has been increasing with one exception in 2022, but then you see a big jump in the last 2 years. So this is concerning, right? Because we are seeing more events, more severe morbidity, and those seem to be still climbing. So a big red flag. You also have two accompanying tables. You have the numerator and the denominator for your specific hospital. Remember, for severe maternal morbidity, your denominators are all births, right? So all births, and you're going to have the numerator being the number of patients that had severe maternal morbidity events. And so then you get your percent. But always, always remember your denominator here is all births. And so when you look at your percent, again, please look at it in the terms of how you compare to other hospitals. If you can access online, how do you compare to hospitals that are similar to yours? And then look at your rate. Is it improving? Is it declining? Or is it stagnant through the years? And then the second graph on the right shows you the differences by race, ethnicity. And so it's important that you look at if you have big gaps, if those gaps are widening or those gaps are getting shorter, right? Which is what we would like to see. If we are providing the same care to all groups, regardless of race, ethnicity, insurance, or other characteristics, those rates or those lines should be closer together. For this particular hospital, we see that there is a significant gap. There was a very important gap in 2020, and then we see that that went down, but as the rate is going up in 2023 and 2024, those are still climbing. So again, another red flag that should be considered. If you access the report online, you will be able to click insurance and then you will get the insurance graphs. So you will be able to see if there's any differences between patients that have Medicaid or that have private insurance. So again, as you go through your report, remember to check for those things. There's an additional graph that is giving you exactly which conditions are making up your SMM rate. Remember, we talked about 21 conditions making up the severe maternal morbidity measure. We present here 8, right? And those are the most common ones. So for this particular hospital, we know that they are having more acute renal failure cases, they are having more hysterectomy cases, and we're having more adult respiratory distress or syndrome cases. And that is in the highest quartile, right? So it's very easily identifiable where opportunities may be. So if this hospital, for example, wouldn't have the capacity to review every single severe maternal morbidity case, at least they should be looking at those that are the most problematic. So again, yeah, when you're looking at the report with your team, try to figure out which would be the opportunities that are most easiest accessible, and then start to review those cases from there if that hasn't been done yet. For PROMPT and OHI, you do have access to severe maternal morbidity among only those patients that had severe hypertension and among those patients that had obstetric hemorrhage. So please, please, please look at your PQI report if your hospital is participating in those two initiatives and help guide the work with those graphs. So again, as we mentioned before, you have severe maternal morbidity among severe hypertension. We are always excluding blood transfusions, right? And here you can see for this particular hospital, the rate is kind of it's a little bit stagnant, right? It has gone down a few times, but it seems to live in between 8.4 and 9.4. So very, very important to look at that rate, how you compare to others, your differences by group, right? And then to remember that for this particular graph, the denominator now is going to be patients that had severe hypertension or preeclampsia, and that is based on ICD-10 codes only. This is not the clinical definition of severe hypertension. These are ICD-10 codes related to severe hypertension or preeclampsia. So again, the big important thing here would be to look at this rate and share with your team, especially if you're working on the PROMPT initiative that is focusing on severe hypertension. You're also going to have an additional graph that tells you which specific condition is most prevalent for your hospital. For this particular hospital, they seem to have more acute heart failure among this group, and again, renal failure as well. So you can identify additional opportunities there as well. And then you also have severe maternal morbidity among obstetric hemorrhage. So if you are working on OHI 2.0, you will be able to see your rates here, how you compare to others as well. This hospital, again, we're using a sample one, is fluctuating. We see some dips and some highs, right? In 2024, they seem to have been going up quite significantly. You can see their rates here in the secondary table. And remember again, the denominator for this graph is going to be obstetric hemorrhage, and again per ICD-10 codes. So this is going to be patients that had a severe event while also having the obstetric hemorrhage during their delivery admission. And again, you want to look at your differences by race, ethnicity, and insurance and figure out if there is any additional opportunities. And finally, you also have those leading types, that secondary graph that tells you what may be the most problematic issue. For this particular hospital, among obstetric hemorrhage, we see that they are doing more hysterectomies than other hospitals in the state. So again, when you're looking at those cases, were those hysterectomies planned? Were they unplanned? What was the story when you review the cases, and is there any opportunity to improve those the care that is provided to those patients? Okay, so for accreditation, we know that the Joint Commission requires the Sentinel event policy. So accredited organizations must have a policy detailing how the organization addresses Sentinel events. So many of you may have already been doing this, right? Doing the case reviews, making sure that you have a process to look into those Sentinel events per policy, and making sure that you have a process to identify opportunities for improvement. So you may already have it. If your hospital is working with the DMV, they are a little bit more flexible. It's voluntary. If you have that report, it's appreciated, but it's not required. So if it's not required, please still consider doing those case reviews. They are incredibly important to keep patient safety and improve quality improvement. And we know that CMS is now requiring some events to be reported, especially along the severe obstetric complication measure. And we just wanted to touch very briefly on what's the difference between the two. And if your hospital is working in PROMPT or OHI, you may already have heard about this. They are similar but different, right? So for SMM and for severe obstetric complications, we know that both are looking at serious health conditions caused by worsened or worsened by pregnancy and childbirth. So we know that those are the severe events, the sentinel events, those near misses that we really have to worry about. And we know that we track those in a way to ensure hospital performance measurement, quality initiatives, and patient safety programs. So both of them are used for that purpose. The difference between the two is quite significant. For SMM, it's defined by the CDC using the 21 indicators that we talked about before, among them sepsis, eclampsia, renal failure, and many others. AIM and other national organizations are now excluding blood transfusions alone, so that's what FPQC is doing as well. When you look at your PQI report, please have that in mind. But overall, it's just using ICD-10 diagnosis or procedure codes to calculate it, and SMM will give you a rate that you can compare with other hospitals in the state in the PQI report based only on ICD-10 diagnosis or procedure codes. That is the big difference between SMM and severe obstetric complications, because for severe obstetric complications, that is an adjusted measure that takes into account the patient's health status or comorbidities at admission. So when the measure is calculated, they are looking at the patient's admission numbers, for example, for their hemoglobin, right? If this patient was anemic at admission, then that will be adjusted for if the patient developed obstetric hemorrhage, for example, because we know that patients that had anemia may have a higher risk of obstetric hemorrhage. So the severe obstetric complication measures adjusted accounts for that, right? So that one is defined by clinical criteria and ICD-10 diagnosis or procedure codes. So we have seen that lately has taken a lot of relevance because of that additional adjustment. Now, we know that that adjustment may not have a huge change in your number. So our request is that you, as you have those severe obstetric complication numbers, you compare them to your severe maternal morbidity numbers, because unfortunately we don't have a way to compare across hospitals the severe obstetric complication measure yet. And so as we get into that, the severe maternal morbidity, the SMM measure, should be used as a benchmark to compare with other hospitals in the state. Hopefully, in the future, we will be able to have more information, more numbers reported from our hospitals, so we can have a severe obstetric complication list or numbers so we can compare across hospitals in the state. But for now, we only have a way to do that through SMM. And as far as it has been seen, those numbers tend to be very, very close. So it should be a very close proxy. But when you think about what's the difference between the two, that is the biggest difference. SMM uses ICD-10 codes only, and severe obstetric complications is going to use additional clinical criteria of the patient at admission, and that is going to be used to adjust the measure. Okay, so I do have a poll question for you. Shelby, could you please pull up the poll question?
Yeah.
And the question is, what accreditation body requires hospitals to have a policy around sentinel events? Thank you so much for participating in the poll. All right, so most of you got it right. It's just the Joint Commission. Those are the ones that have a policy regarding, having to report sentinel events. They have to have a policy around it and how they handle them. CMS is now requiring that you report the severe obstetric complication measure. So that is something that some of teams are learning about, and some of them already have it in place and have completely turned to. So we know that this is transition time. And this is another question: where do we find SMM numbers? Most of you responded correctly. It's actually the three of them. It's a little bit of a trick question. Anywhere that we have ICD-10 codes, we are going to be able to calculate SMM numbers. So on your end, electronic health records, you can calculate them because you are the ones documenting ICD-10 codes. We, as FPQC, we get it from the inpatient hospital discharge records, and other organizations also use Medicaid claims data and other claims data information to calculate it, since those also have ICD-10 codes. Wonderful. Okay, so that is all I had for you for SMM. And I did want to take a second to raise this alert. We have been seeing an increase in the rates for NTSV cesareans in the state. You can see here our graph for the state, and you can see that in 2018 we have a 30.6 mean for the state, and that went down while we were working with Provide, which was our NTSV cesarean initiative. Remember, many of you participated in that initiative. As a state, we were able to go down in the rate while we worked on it, which was fantastic to see. We were also able to see a decrease in the gap. So you can see that Hispanics have always been the ones that had the highest rates. But during that time, that went down. In 2020, that was actually a very nice dip. But since then, we have been seeing a consistent increase year to year. Yeah, so we have now 1, 2, 3, 4, 5 points going up. And so that is in quality improvement very concerning, because we know that that is almost the rule for significant change, right? And that is the wrong way that we want the change to go. We for sure want to see NTSB cesareans going down. So this is something that definitely has to be worked in the units. And that is not an active initiative for FPQC, but we do have a huge amount of resources in our website related to decreasing NTSB cesareans safely, supporting vaginal births. There's a lot of resources on, labor training that are available to you. And we also have a lot of very passionate physicians around the state that would be happy to connect with you and provide run rounds if there is any interest. So please, 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 once you get your PQI report, make sure that you look at your NTSV cesarean rates. Look at them yearly, look at them quarterly, look at them monthly. Those are the graphs that are available to you. And if you see your rates going up, please make sure to speak with your team, have a plan in place, and if there's anything that FPQC can do to support you, let us know. We are an email away. But it's really, really important that you help us out looking at your specific rate and that you have a plan in place, either to go back to what you did during Provide, or if you didn't work in Provide, to hopefully access one of our resources or the many resources available in the AIM website, and work with your team to help us stop this increase. Okay, that's all I had for you. And for the next section, I'm going to leave you with Alexa.
Great. Thank you, Stephanie. Will you run the slides for me?
Sure.
Thank you. So Stephanie had touched on this a little bit earlier, but we did add a new slicer to your report. So if you are already verified a level of maternal care verified hospital, you have access to this slicer on the bottom right, where you can, on several pages in your PQI report, separate out the data based on the level of maternal care. And that allows you to compare yourself to the other hospitals in your verification level, which as Stephanie had talked about the importance of earlier. So anywhere that there's a slicer where you can slice by NICU level, you can now also slice by level of maternal care. Next slide. So levels of maternal care is an initiative that we've been working on for a while. Sarah kind of spearheads that for FPQC. We're really excited to have 38 verified hospitals in the state, and it covers more than 50% of the births as of 2023 data. Next slide. If you have questions on levels of maternal care, how to do it, what it looks like, how to get the process started, you can go to fpqc.org/LOMC. And you can also contact Sarah and Candy, and I'm sure Sarah's probably in the process of putting her information in the chat. If not, I'll make sure it's in there before the end of the call. Next slide. For the PQI reports that we've been discussing, you all should have either completed the PQI survey or be in the process of completing the PQI survey right now. We will have reports sent out by the end of June. So if you haven't done your survey yet, please do so. You will also be receiving reminder emails from Shelby and I, so that you don't forget. Next slide. So we do have a ton of resources related to PQI. If you want to learn how to read your PQI report, there's several modules on our website under the PQI section. If you want guidance from us specifically on reading your report, you can always email us to set up a call. And then if you're not sure who your PQI liaison is, or you maybe need to change them for whatever reason, email Shelby and I, and we can get that set up for you, or we can get you that information. Next slide, which I think is just any questions. So
Yeah.
now's the time for questions.
Absolutely. Thank you, Alexa. I don't see any questions in the chat. Yeah, Lori added a note about the funding support for hospitals. Lori, can you tell us a little more about potentially how many hospitals we would have covered once they go through the accreditation? I'm trying to remember.
Hi, thank you.
Okay.
Yes, so we have 38 hospitals now, and we have about 6 more that we expect to be verified sometime in the next couple of months. And that's going to put us at somewhere around 60% of all the births, all the deliveries in the state, which is the majority, right? And so we have basically about 1 more year of funding. We do not expect to get additional funding from the state after that. So really, really want to push to get as many hospitals verified as we possibly can. It's important for so many reasons. I know that it's also a priority for ACOG and the Florida Hospital Association. So please let us know if you have not started the process yet and you're interested. We will hold your hand as much as you like through the whole process, but it's definitely worthwhile. And hospitals that have become verified talk about the value of it often. So I just saw 2 hospitals present last week, and they both put their verification up front and center on their slide decks. They're very proud.
Absolutely. It's so exciting to hear that we have at least one more year of funding available, and we have a wonderful team that will support you. It's been fantastic also seeing the collaboration between hospitals and how they have supported each other through the verification process. So it won't be a lonely road. You will have a lot of people to help you through. So, Sarah is your contact person. Lori is always there to support you as well. So please make sure to, discuss it with your team, get excited about it, and email us to get it started. But that's all we had for you. Thank you so very much for joining us today. If there is no more questions, I don't see any other questions in the chat. But we will give you back those extra minutes. Thank you so much for sharing them with us. And the webinar will be uploaded in our YouTube channel if there's anyone else that you would like it to see. Thank you so much for joining us today. Have a wonderful, wonderful afternoon.